Oh, also, we're up to date on YouTube. If you guys want to go back and look at anything, I was able to post a couple of PowerPoints. I'm still trying to keep the postings somewhat small because I don't know how much room they gave me on Blackboard. They're usually pretty stingy about that. But in any case, how did you get moved here? All right. Well, without further ado, need more. Okay. Without further messing around, let's start talking about the adrenal glands. So, as you guys know, at least I think you know, they're the cap on top of the kidneys. Each kidney has an adrenal on top of it, kind of superior and medial, so it's kind of like wearing its hat down low, like it's really cool. And each gland is unusual in that it has two distinct glands in one organ. Not only distinct glands, I mean, you have glands that put out different hormones, but this gland is created from two completely different cell types, which is kind of cool. The medulla is just like a kidney, the medulla is on the inside, and that develops from neural crest cells. So neural, as in neuron, crest cells. And these are the same cells that create the sympathetic ganglia, or part of the sympathetic nervous system. So that's part of the system that kind of keeps us alive, the fight or flight, non-conscious part of our system there, our nerve cell system. I can't think right now. The second part is the cortex, and just like the kidney, the cortex is on the outside. That develops from epithelial tissues near the gonads. So the gonads are created, remember, they're created up high in the belly, and center, and as well as these, the cortex is developed right in that same area. Once again, if there's a developmental mistake in one, there could be a developmental mistake in the other. They kind of go hand in hand. Oh, and one of the things I'll tell you, I was so frustrated. I had that whole blank area. It used to be filled with stuff, and I lost it all. I hadn't saved anything, and I lost it all, and I'm really frustrated. It's just words. I can do it again, but I'm going to have a hand cramp by the end of this. So on our cross section here, oh, you know what I'll mention now is kind of the general shape. Where did I have that? Where did I have that information? Oh, that was part of what got erased. Okay, the general, and that's why I forgot it. Let's go back to my notes, since I lost so many of my on-screen notes. Very close to, but not attached to the kidney in any way. So, okay, let's talk about that first. These guys, if I were to draw a kidney under here, kind of top of the kidney, kind of comes up like that, real close to, let's say that's the right, whoops. Let's say that's the superior pole of the right kidney. There, it's within the renal fascia. So if the renal fascia came around, and you got all the fat in here, it's within the fascia. However, it is very independently tied in. So, you know, there's little. So if the kidney were to move, the kidney were to be removed or to slide out of place or be ectopic, This guy still is in the same location because it has its own attachments. Lots of mess there. Let's get rid of some of that. They are retroperitoneal organs. Let's go ahead. Let's write that up here. They are retroperitoneal on the superior medial surface. So, you know what's the one thing? Oh, you know what? I do have a picture. Wow, that's a horrible picture. It's meant for something else. But on both kidneys, superior as in, superior as in up, and medial, they tend to be more on the medial surface. In fact, they'll even say like the right adrenal gland is posterior to the IVC. Now, when they say that, it's not like, yes, it is more posterior than the IVC, but it doesn't necessarily mean it's all the way behind the IVC. However, an adrenal tumor can lift the IVC. So that's one of those things where if you ever see, if you're looking at the IVC, or for that matter, the aorta, anytime you see a vessel do that unexpectedly, what's underneath it? And in the case of the IVC, it very well could be the adrenal gland. So let's come back up there. The right adrenal, shaped more or less like a pyramid, so we'll call this the right adrenal here. That looks like a right, it's pyramid shaped, whereas the left is a little more like a crescent moon, and that's just simply the way it is placed in there. With the surrounding organs, with liver in the area versus spleen versus pancreatic tail, all of those are in the same spot. Okay, so now I can come back down and talk a little bit about this. Let's talk about the innermost first, and that's the medulla. That's the kind of, on here, it's the more purple section there, and that's interesting. It is pretty much directly connected to the nervous system, so the splenic nerve. So it's almost a part, you could say it's a part of the nervous system. And what you have in here are chromaffin cells, and they create epinephrine and norepinephrine. These guys, well, they will, when they're released, they increase heart rate. They increase blood pressure. They increase respiration. They decrease things, unneeded things like digestion. So let's think about epinephrine. This is our fight or flight. Fight or run, or just stand there and freak out and shake or cry. All those things, shaking, crying, fighting, running, all of those are, when you're under stress, when you're under danger, that is a result of a huge amount of epinephrine and norepinephrine going into the bloodstream, increasing that heart rate, increasing that blood pressure and respiration, decreasing digestion, because the body doesn't care about digesting if it's about to be digested by something else. So if you're going to get eaten by a tiger, who cares if you're going to finish digesting that burger? So in one way, it reduces digestion and other non-essential at the moment actions, is by decreasing the size, or let's do vasoconstriction of certain vessels. So vasoconstriction of the smaller vessel, of the mesenteric vessels, the SMA, the IMA, you don't need those vessels, blood going through to the intestines at the moment. You need blood going to your muscles and your leg muscles and your, you need to expand. You need more blood for all of that. You need to increase your blood pressure because that helps you from not, from passing out. So that's all created by the medulla. And we'll talk about a little bit more about how that happens in just a moment. And then outside of the medulla is a cortex. And the cortex is, that's 90%, let's see, cortex is 90% of the weight, of 90% of gland is cortex. And it has 3 levels. And of course, the first level is just really closely related to that other word I can't say, glomerulosa, that's it. And then is that the same that we use in, yeah, the zona is zona glomerulosa, zona another word, fasciculata, sounds like I'm trying to speak Spanish, and then reticularis layers. And each one of those has their own kind of reasons for it being. The first layer is for aldosterone production. Aldosterone, remember, that was actually a part of the renin angiotensinogen complex or pathway. That aldosterone was part of that, and it helps us with H2O balance, how much blood or how much water is in the blood versus out into the tissues. And it does that by more or less an increase in aldosterone will retain more sodium. Remember, sodium is Na on the chart, on the periodic chart. Sodium is Na, and expels potassium. Potassium is K. So that's when you increase aldosterone, you retain sodium, and you expel calcium. You retain sodium in the blood, and that pulls water into the blood by osmosis alone. And the next one is cortisol, and that's in the zona fasciculata for the most part, and that's where your cortisols come from. So that's a stress hormone. You know, some cortisol is good. Lots of cortisol over a long period of time is bad. It'll make you go bald. And then the innermost layer of the cortex, that's where our estrogens and androgens are created. Estrogens are the more female hormones, androgens more male. And it doesn't matter if you're a male or female, you produce both estrogens and androgens in different amounts. Okay, so let me back this up a little bit. And how do we control this? Because how does a organ, for instance, let's talk about the fight or flight response. How does an organ that is all the way down in our abdomen change our physiology so quickly? Because when a tiger comes running after you, you don't have 5 minutes to wait for those hormones to kick in. You need those hormones instantaneously. And there actually is there are instantaneous pathways that produce tiny amounts of hormone, and then this hormone follows. But still, this pathway is very fast. The instantaneous pathways are literally nervous pathways to the lungs, to the heart, more or less to the muscles, that can release small amounts of hormone directly from nerves. So it's kind of a strange thing, but the spaces between nerves, those I'm getting into the weeds. Never mind. But in any case, how does this happen so quickly? Well, directly from the brain. Our brain, through our eyeballs, or over here. Oh, no. Oh, I just put the eyelid on the wrong side of the eyeball. All right, well, here's our eyeballs, and they're freaking out because they see a tiger coming at them, and they're gonna go back to the brain. The brain's gonna say, "Oh, sugar," and it's gonna send a signal down a nerve fiber, the parasympathetic signal down this fiber. This is a ganglion right here. Just ganglions they're almost like little mini processing centers, because you could have one ganglion and lots of nerve fibers coming off a ganglion. So they're kind of like they're almost like tiny little brains. But in any case, it comes all the way down and bam. So our adrenal gland, our medulla, and the chromaffin cells get pretty much instantaneous information when we are in danger, when we need that fight or flight response. By the way, if you don't use this response, like if you have a reason to fight or run, or a reason to really be scared about something, and you do nothing with your body, you play it cool, you will have a physiologic reaction after the fact. And it's happened to me a number of times in my life where I've had pretty traumatic things happen, and then I don't react, I play it cool, and then half an hour, 20 minutes later, I cannot help it because all the epinephrine and norepinephrine in my body is just still surging through, and you start to shake a little bit, and that's kind of unused. When you shake like that, that is unused hormones. So that's really all we need to talk about as far as the brain medulla interface. The brain sees danger, it goes to the medulla instantaneously, pretty much instantaneously, and those hormones are released, and very quickly they go throughout the body. The other hormones, we don't need these to happen so quickly. So we have what's called the negative feedback mechanism, where if a hormone goes down in the blood, the pituitary gland and the hypothalamus in the brain sees that and says, "Oh no, you need more." And then the hormone goes up in the blood, and then the brain says, "Nope, you need less." And then you need more, and then you need less. And so it's just a back and forth. It's just one big continuous circuit throughout your entire life. It never ends. That is a negative feedback mechanism. And then, so that includes aldosterone, cortisol, estrogens, androgens. They all go through the bloodstream. And as they're going through the bloodstream, they travel and go through the hypothalamus. Ooh, I have a little something up there. There we go. They travel and they find their way through to the hypothalamus. Hypothalamus says, you don't have enough aldosterone. So, and actually it's the anterior pituitary gland, so I should have had this go through here. Hypothalamus, through two methods, I don't know how much you have of this, but it's kind of cool. there's nerve fibers that run from the hypothalamus to the pituitary gland. Very short fibers, and they can obviously transmit information from the brain to the gland. There's also a portal system, just like our portal system in our abdomen, the portal system going from our intestines to our liver. There's actually a tiny 1 centimeter long portal system of arteries, veins. Let's draw just really quickly. It's not that important, so I'm just going to kind of draw this little portal system in here. And so, I'll just go ahead. And so sometimes what the hypothalamus will do will actually create a hormone, put it out into the circulation, in other words, the portal circulation. It goes all of 1 centimeter, 2 centimeters at the most, to the anterior pituitary gland, where that hormone acts on the anterior pituitary. So there's 2 methods of going from the hypothalamus to the anterior: portal system and nerves. Anyhow. Get you out of the way. All right. Back to black. So hypothalamus is going to see, my aldosterone or my cortisol levels are a little bit too low. I'm going to release corticotropin releasing hormone into the portal system, into this portal system, not our abdomen. And it goes all of 1 centimeter down to the anterior pituitary gland. The anterior pituitary gland is going to create ACTH, adrenocorticotropic hormone. That hormone goes down. Sometimes it doesn't work so well. Goes down to the cortex and tells it, hey, you need to be more active here. That's kind of the basics on, oh, that's right. So let me, heart rate, sugar, directly stimulated by autonomic nervous system, cortex, and 3 layers. All right. Not actually in my notes, but I have it down here for a reason, so as not to forget. Your book mentions organs of Zuckerland, and that's this is where you find Facebook. Hold on. Arm is sticking to the table. Okay. Organs of Zuckerland. You will not ever see these unless there's something wrong. Unless there's something wrong with them, then maybe you will see these organs. There's a tumor on them, but there's no way you're going to know, oh, there's an organ of Zuckerland tumor down here near the aorta, and yeah, you're just not going to know that. No one's going to know it. No, the doctors aren't going to know it. No one's going to know it. If you see anything down here, if you saw, like, let's say a lump down here, some kind of mass, any radiologist is going to say, they're going to say lymph adenopathy. You know, that would be the first consideration for any kind of lump, because there's plenty of lymph nodes all along the great vessels, the aorta and IVC. So these organs of Zuckerland, and I'm only mentioning this because the stupid book had to mention it. Otherwise, I'd be more than happy to avoid talking about this. But remember, this medullary tissue, this came from sympathetic nerves. So they all kind of came from the same point. And so the organs of Zuckerland are kind of like, they're not, but they're almost ectopic medullary tissue. Almost. I guess one thing that, you know, a tumor specifically of adrenal medulla can actually be found, the same exact tumor can be found on this because it really is the same tissue as the medulla. And that's probably the only good reason for us as sonographers to have any idea about that. Okay, this is the part that I was not looking forward to because I had so much written down before. Oh well. What time is it? 1:32. Awesome. Okay. Let's call this section congenital. In other words, from birth. Anomalies. Congenital anomalies. The first couple that are in your book, I forgot what the subheading in the book is, but the first couple, in fact, here, let me. Developmental anomalies. O and my A mixed up. Congenital or developmental anomalies, same difference. The first one was hypoplasia. Well, actually, the first one's agenesis, which I don't understand. These are really important organs. You don't have them, you don't live. So I'm not, and it doesn't really say anything about it. So we'll skip that entirely and call hypoplasia, and I'm going to say hypoplasia / ectopic. These are very different things. Hypoplasia just means smaller than normal. Ectopic means not where it's supposed to be. But with these two, I'm just going to write good luck. We're going to learn shortly that these organs are, the adrenal glands are extremely hard for us to see unless we're talking about a neonate or a fetus. These are very hard to see. And so to be able to say, oh, that one's too small, or though I can't see it where it's supposed to be, it must be ectopic, or I found there's a little tissue near the aorta below the kidney, below the level of kidney, it must be an ectopic adrenal gland. No way, it's not going to happen. You can't do it. We're not that good at all. So we will. That's all I have to say for that one. Cysts, yeah, mostly rare. We don't see them a lot. They could be simple cyst, you know, just a, oh, I want my sort of make it back. Simple cyst with through transmission, thin walls and all of that, anechoic. They could be hemorrhagic, so a simple cyst that bled into itself, probably still have through transmission, but it's, you know, it's hemorrhagic, so it doesn't look as pretty. What else do we have for cysts? We have, I don't know. Pseudocysts, those are more likely to be post or after adrenal hemorrhage. Not a hemorrhagic cyst. I mean hemorrhage, as in the adrenal gland is bleeding. And adrenal glands do bleed, by the way. They're very vascular structures. So pseudocyst might be post-hemorrhage. It's just kind of whatever's left over. And when we say a pseudocyst, we're usually, personally, I'm not thinking of a adrenal gland. So I don't like the term pseudocyst here, but it's pseudocyst really means without a wall. Or without a real wall in any case. There's no endothelial wall, there's no cellular matrix wall around it. It's just whatever is walling it off is not an organized wall as such. Okay. So, hemorrhage. These are very vascular structures. They can hemorrhage. Most likely, let's see, I'll say number one is traumatic birth. And we'll equate that with prematurity. So preemies oftentimes get hemorrhage in their adrenal glands. Oh, and traumatic birth, I don't mean not traumatic as in like, they dropped them. Traumatic as in low oxygen and blood. That causes problems in prematures in the adrenal glands. It also causes problems right in the middle of the brain. And that's something we'll learn. Yeah, this semester, we learned this semester how to do a brain ultrasound, which is actually pretty cool. But low oxygen conditions during birth can cause hemorrhages in a couple of places in the body. All right, so what was the next one? Oh, the abscess. So once again, this is rare. Hemorrhage is common for neonates, rare in adults. And abscesses are rare as well. But an abscess, it's the same thing as anywhere else in the body. People who get abscesses are, well, they might be because of a previous hemorrhage. That hemorrhage gets infected. That becomes abscess. The other possibility is immunocompromised patients. So like AIDS, for instance. AIDS patients are more likely than others to get an abscess. Let's see. And why would, I think it's your book's fault. I just didn't even notice it. They put congenital or developmental anomalies, and they put hemorrhage and abscess under that. Well, obviously, I disagree with calling hemorrhage or abscess as a developmental anomaly. Maybe I'm misreading how the book is organized. But they are anomalies. Those are not good things to have. Let me just erase this guy. That's a little bit in my way, huh? Where's my eraser? Okay. Some more pathology, but more real pathology. So cortical pathology. So remember the outside, the cortex kills me. I always think of a core as being on the inside, but a core, when it comes to the body, is on the outside, even though your core temperature is your inside temperature. Cortical pathology. First one, Addison's. Anyone know what very famous president? Hi. What very famous president? And Addison disease, let's see if anyone. Anyway, they're bit of a playboy president, but a very good president overall. No one? Nobody?
Was it Bill Clinton?
No, his idol, Kennedy. God, all right. I can't even spell Kennedy. K-E-N-N. Anyway.
U-H-D-Y.
Shut up. Addison's disease is caused by atrophy of the adrenal gland. When that happens, the whole negative feedback system, you know, going from the gland, from the adrenal gland, and okay, so you know we're creating we're creating adrenal hormones that goes to the brain. The brain says, we have enough, and because you get that kind of that feedback mechanism that happens during our whole life. It's always going on. Well, when you have an atrophic gland, you're not producing enough, so you're always creating what's it called? ACTH. And of course, such an idiot, adrenocorticotropic hormone. You're always creating adrenocorticotropic hormone, and well, that does a couple of things. One, it actually acts on, and this is fairly rare. It acts on melanin. So almost everyone with Addison's disease gets darker skin. And Kennedy was known for he always had bronze skin. I don't know about orange skin, but bronzing of the skin is a telltale trait of Addison's disease. And I don't know what the mechanism, why it connects to melanin. It just does. And that was. And also, so now we have this hormone increasing, but our other hormones decreasing. The actual adrenal hormones are decreasing. So sodium and A and potassium, which is K, they're both increased in the blood. That actually can cause renal dysfunction. So renal dysfunction, increase in sodium and potassium. Because usually it's sodium goes up, potassium goes down, potassium goes up, sodium goes down. But in this case, they're both going up. What was the last thing I had? Oh, overall weakness, nausea, vomiting. When you see on a script, why are you doing a right upper quadrant ultrasound? N/V, nausea, vomiting. So that is most of Addison's disease. There's a second one that is similar, but not quite Addison's disease. That would be chronic secondary hypo, so low adrenalism. So Addison's is hypoadrenalism, but with chronic secondary hypoadrenalism, it's going to have some similar results, except this one actually has ACTH is decreased. But this is what, let's see. Let me get rid of this. Just I feel it's a little slightly confusing. ACTH decreases because of a problem up in the brain, not down in the adrenals. So that decreases. Remember, ACTH, that's what acts on the gland to increase production of adrenal hormones. And so let's just say, I'm going to say brain issue. But then the other causes, and then it's similar to Addison disease, except bronzing of skin. So since the ACTH is actually low, the melanin is not going to be increased on people with chronic secondary hypoadrenalism. And the way this happens, the most common way, is when it gets low on the screen, it's actually low on my writing pad too, so it makes it really hard to write. Abrupt, or let's see, caused by abrupt cessation of, let's say exogenous, I don't want to say exogenous, but let's just say corticosteroid use. So if you've ever been on corticosteroids, and I was on once, I forgot why. I can't remember why I was on. My doctor, first of all, she looked at me and she says, okay, corticosteroids aren't going to make you bigger. I'm like, oh, damn it. But I knew that already. And she also said, do not abruptly end use of this. You know, when I say, you know, use the entire pack and use them in order, she means it, because if I went from corticosteroid use and then just stopped it cold turkey, that feedback mechanism's really messed up. And so that can cause this chronic secondary hypoadrenalism. And it's chronic. So, you you mess yourself up, you can mess yourself up for a while. So you gotta be careful with corticosteroids. They aren't toys. And actually, just so you know, if anyone's ever thinking about taking steroids, if men who abruptly end steroid use are more likely to cause permanent damage to their own testosterone synthesis abilities or synthesis. So that Don't want to mess with your hormones. Okay, so both of these, by the way, let's do a different color here. Let's do a nice blue. This was chronic secondary. It was hypo, so I'm just going to write that over here. Hypo. Hypo. Addison's disease was hypo. And the next one we talk about, though, is hyperactive. And let's see, that is going to be, what is that going to be? Cushing's syndrome. My sister's dog had Cushing's syndrome. Actually not terribly uncommon in dogs. With Cushing's syndrome, there's two basic mechanisms for it. There's either a increase in ACTH. So if you have an increase in this, and whether that's caused by the brain or caused by something else, in any case, when you're increasing this hormone, you're increasing your adrenal hormones. The other possibility, I'm going to call it a hyper functioning adenoma. So you have adenomas. There's a few places that we find the adenomas in the body, and other tumors as well. It's not just adenomas. A lot of times, it actually happens in the ovaries a lot too. A lot of times they're always benign, but sometimes they're just there. They just sit there. Other times they're hyperfunctioning. Whatever adenoma, whatever tissue was created, or it was created out of, hormone-producing tissue that it was made out of, those hormones can be increased throughout the body because of this adenoma. So those are two reasons for Cushing's syndrome. So let's see, just going to put a 1 and 2 here. And then below that, well, kind of overall below, no, it's going to mess up my, in any case, either one of these can cause, increased glucose. Glucose is bad for you. You don't want a lot of glucose in your body. Having too much glucose, it's going to cause you to gain weight, but it's also, over time, going to cause you to develop diabetes, mellitus, type 2. So type 2 is the kind of diabetes most, am I saying that right? Yeah. Type 2 diabetes, most of the time it's because of obesity, really poor diet, eating sugar all the time. But Cushing's syndrome, you could be very conscious of your diet and exercise and all that, but still your glucose is always high. Creates diabetes mellitus type 2 because the cell receptors for insulin have just gone, they've been overused and they no longer work. The other thing about Cushing's syndrome is protein loss and weakness, right? Yeah. Weakness, and then grief. Osteoporosis of the bone, and then last but not least, well, not even last, but it's the last one I'm writing, hypertension. Now, the thing about Cushing's syndrome, we need to know a little bit about it, but you can't really look at it. You're not gonna see Cushing's syndrome. You're not gonna say, oh, look at that adrenal gland. It must be Cushing's syndrome. Not gonna happen. But since it is such a prevalent thing, you need to know a little bit about it. Right here. Another one, which is also Con syndrome. Movie reference. Con syndrome, that is a increase in aldosterone, most likely caused by an adenoma. So that's what I was just saying. Some adenomas just sit there, do nothing, but take up space. Other adenomas are hormone producing. So this adenoma produces excessive amounts of aldosterone. And these people have hypernatremia. That is hyper, too much natremia, salt. And then it also causes hypokalemia. Hypo, not enough potassium, because potassium and kalemia and natremia and salt, they all make sense to me, but that is hypo, and so not enough potassium. And that is all I have to say about Con syndrome. And then the last, let's see, the last last page too. And 2 o'clock. So let me just finish this one. One last hyper. Oh, this one's kind of cool, actually. Congenital. Oh, one more time. Still horrible. Adrenal hyperplasia. Congenital adrenal hyperplasia. That is from birth. Well, it can be from birth. Well, it's congenital. It's going to be from birth. Adrenal gland overgrowth. So, and it actually ends out looking like a brain. The sulci and gyri, the gyrus and the sulcus, those are what that's what brains, the surface of the brain looks like a bunch of worms. I don't know what else it looks like. Actually, it looks like a brain. So, if you ever see it, I got a picture of it. I've got a little PowerPoint. It's only pictures. We'll look at that later. And because it is big and too big and a little too active, it creates excess androgens. So if you're a female, my little helper. If you are a female, well, it's excess androgens. Let's write this very, how do you spell? Virilization. That's basically too many male hormones. Females could have babies can have ambiguous clitoromagaly, a fused labia, a labia that actually looks like a scrotum. So that's a possibility with females, and males born with this have, well, here, I'll give you a hint what could happen in the males. Yeah. And then also, what can I think of? Early, oh, that's right. I couldn't think of the word. Good gosh, Kurt. I totally misspelled that. Precocious puberty is a possibility with that. A lot of stars have that problem. I better stop recording before I get myself in trouble here. Missing half the class, I see. Well, their loss, it's already 2:17. Okay, so the book mentions the incidentaloma. That is just, I like that. I like that term. It is just it is a cute term, like literally cute term for any unexpected neoplasm, whether it's cancer, adenoma, cyst, incidentalomas. Found them incidentally. And that's what we find, things incidentally all the time. So those are, it's kind of its own thing. In fact, I'm gonna give it its own little circle there. Adenomas, adrenal adenomas they're not rare. Let's go ahead and put what happened there. Common, or at least common enough. They are, all right, this guy's got to go. They're common. They are homogeneous when we see them, most likely hypoechoic, not anechoic like black, but hypoechoic like darker. Adenomas often occur with men. Actually, no, not men as in males, men as in multiple endocrine hypoplasia. So let's go ahead and multiple endocrine. No, I'm sorry, hypoplasia. I'm so used to saying hypoplasia. I started writing out. I'm like, well, that's not right. Neoplasia. So there's a couple of syndromes that fall under men, multiple endocrine and neoplasia, and these people have multiple endocrine tumors and neoplasias. If the adenoma is small, it is likely non-functioning. Let's see, I'll say like non-functioning. And if it is large, it is more likely to be functioning and hyperfunctioning. Let's just put a hyper there. So, you know, having Conn's syndrome with an adenoma that puts out a hyper amount of aldosterone is probably a large-ish tumor, adenoma causing that to occur. Myelolipoma. These guys are going to be, when you see them, I can tell I had to increase my canvas size, and I could totally tell. Hyperechoic. Oh, and they are a lipoma, myelolipoma. And so what often happens, what happens when we go through a fatty tumor? Speed of sound changes, so you will have a speed artifact behind it. So that's one way to really know that you're looking at a fatty tumor, is looking for that speed artifact. And these guys are non-functioning. And so who cares? Who cares about them? We don't really care about them, but if we see that speed artifact, then we could say to the doctor, hey, there's a speed artifact, and maybe a lipoma or myelolipoma there. Now, the chapter has one tiny section on cancer. Doesn't really get into it all that much, and I think because it's rare. It is often, when we do see cancer, or when someone does have adrenal cancer, they are just like an adenoma can be hyperfunctioning. The cancer can be hyperfunctioning, and in this case, maybe huge. Huge. I used to live in central New York, and there was a guy there who sold cars. Everything was huge. Drove my father-in-law crazy, which is why I liked him. And that's it. As far as cancer, that is all I had to say, because as I read that, it just was not worth getting into more than that. Other than that, it's rare and hyperfunctioning. This next one is rare, but it's a little more. It's a very specific adrenal tumor, which causes very specific adrenal tumor symptoms, and that is the pheochromocytoma. I think actually the cells, they're chromaffin cells. Remember, in the medulla, they're chromaffin cells, and I believe they used to be called pheochromaffin or something like that. So pheochromocytoma is basically referring to those cells. So that's actually just write that here. It's a tumor of the medulla. And so, and remember, guys, that so maybe not let's give myself a little more room. So maybe not in adrenal. Pheochromocytomas could happen in the, oh God, what was those, can't remember what they were called, organs of Zuckerlin, or they could actually occur in a number of places along the sympathetic trunk, because these are all the same types of tissues that you find in the sympathetic nerves of the medulla. So pheochromocytomas, they're more likely, the most likely place to find one is in the medulla of a adrenal gland, but it doesn't have to be there. It can be, and it'll have the same exact effects even if it's somewhere else. Okay, so what do these guys do? Well, let's do this first. This list first. Hypertension. Something I added, a racing headache. The people who it's a kind of headache where it's like it's not, it doesn't just hurt. It's like literally like a racing feeling, and that probably is, the racing feeling is from the huge amounts of adrenaline that's going through your body. So hypertension, racing headache, sweating, tachycardia, in other words, that's, you know, that's your heart rate is increased, or tachycardia, or feeling you're taking a U.S. physics exam. So if you feel like you're taking a U.S. physics exam, even though when you're not, you might have a pheochromocytoma. Now, these guys, there's a rule of 10. Here, I actually have to erase that because I need the room. Yeah, obviously, tongue and cheek. Gosh, did I leave myself enough room? I did. But I'm going to put my rule of 10 down here. Rule of 10 with pheochromocytomas. 10% are malignant, which means, of course, 90% are not, but I don't like that 10% odds either when it comes to my life. 10% are multiple. Multiple on one side, bilateral, maybe one in the adrenal gland, and then one in somewhere else in the body or in that central nervous system, ganglia. 10% hereditary syndromes like men. So hereditary syndromes like multiple endocrine neoplasia. 10% are pediatrics. Oh, am I gonna make it? No, let's just right over here. 10% how do I spell it? Paraganglioma. Oh. In other words, 10% are not in the adrenal gland at all. They're in the paraganglioma. And 10% are non-functioning, which is kind of weird. I kind of always thought that the hallmark of a pheochromocytoma is that it is functioning and that it causes hypertension, racing, headaches, sweating, tachycardia. But, oh, and what do they look like? They look like, oh, that's right, I did write it down. Thank you, Kurt. They don't look like anything. Wide range of appearances. So hypoechoic, hyperechoic, smooth, rough, has all sorts of different appearances. So we really can't look at it by itself and say pheochromocytoma. I would say most everything. Oh, I'm getting seasick. The only, gosh, that was smart. Here, let me just give myself one little area here to write something in because I barely have anything else to say other than, what was it? Oh, so it mentions neuroblastoma. That is a very important tumor, but we're going to cover that in pediatrics because it is a childhood tumor. And then it just mentions metastasis. Really the only thing I have to say about that, and I was surprised by this, fourth most common organ. Fourth most common organ for Mets. So I forgot it was liver, lungs. I can't remember. All right, let me just pull up real quickly here, and we will be done after this slideshow from current slide. The adrenal gland. Good luck seeing it. Now, you can see it. For most sonographers, it's kind of either they don't think about it at all, or if they do think about it, it's kind of in the back of their brain, and that's probably where mine is, usually in the back of my brain going, okay, anterior, I'm sorry, well, a little bit anterior, but mostly anterior, superior, and medial to the kidneys is going to be the adrenal gland. Now, on the adult, very hard to see if it's normal. Neonates and fetuses, different story. We could see those. They are much bigger as compared to the rest of, they're bigger in comparison to their body as they are for us, I guess we could say. So let's get my little spotlight. Get rid of you. How do I get rid of you? All right, leave it there. Here's a adrenal gland. You can really clearly see the hypoechoic cortex and more the hyper, or at least as comparison to the cortex, hyperechoic medulla in the middle. And the same thing over on this side. We don't see kidneys because we're just above the kidneys. I know this is the left side, assuming this is a normal baby, and I'm sure it is, because we have a stomach right here. Now, of course, this and I'm assuming you guys know what we're looking at. So this is a fetus, baby in utero. Back is straight up, so that's the spine here. Adrenal gland, stomach over here. So this is the left side of the body over on this side. Split screen on this baby. It looks like more or less sagittal image. I guess sagittal on this side and transverse on this side. Well, in any case, a split screen. So this is one adrenal gland. They've measured it in 2 different directions. They've measured the thickness, and they did it incorrectly here and here. Here's why it's incorrect. Can I draw? Oh, now it draws. Okay. This is the direction of the, and of course it doesn't go away. Well, more or less, the direction of the gland is that way. If you're going to measure, I hate you. Oh, for God's sakes. Please tell me I don't have to deal with this whole. So there's something special about that one. All right. Well, that just. Will the eraser work? I should know better. All right. Well, I don't know if it's cleared on your end. It's not clear on mine. Okay. Well, in any case, I don't like the way they measured it, and now I really regret even mentioning it. Okay. Neonate picture. So brand new baby. Here's a little kidney, little liver. So most likely, I really doubt that's spleen. So this is the right kidney, liver. And also, I know that this is really triangular shaped. So that makes it more likely this is the right kidney. L obviously stands for length. Neonate adrenal hemorrhage, traumatic low oxygen birth, often premature. Please get you out of there. Okay. Stop messing with the curtain. So adrenal hemorrhage on this picture. If they are big, we could see them, is that 2 words? In adults too, or as well. So right kidney, you don't see the adrenal right here. We had to go a little bit medial to the right kidney, and we saw this adrenal. That's huge. That's a big adrenal gland. So something's wrong with that one. Sometimes they like to lay down. Yes, look at this guy. Look how this is right. Yeah, right kidney bed. Right kidney bed. That gives us an idea right there. There's no kidney here. There's no kidney. And so the shape of this is different. Without a kidney there to shape it, it grows in the direction of least resistance. So they call this the laying down sign. Interesting image of a long, straight adrenal gland. Remember, the right adrenal is shaped like a pyramid, but with no kidney around to tell it how to look, it lays down. So that's a sign that there's, we could do that in utero as well. You can see that the kidney is not there. Kind of like a single guy, he's just laying there. He doesn't know what else to do with himself. This one is normal. Son of a bee. All right, that's it. Hold on, guys. Escape. Discard. Oh, good. All right, there we go. Really good tech here for them to find this, but you can see it's kind of a little bit of a zigzag, but overall triangular shape. That's the right again. Congenital adrenal hyperplasia. Remember I said it looked a little bit like a brain? Look at that. Look at all that gyri and sulci. It looks a lot like brain tissue. That is way too big. So the female ambiguous genitalia, too many androgens, virilization. Adrenal hemorrhage. Once again, you could Yeah, you can pretty much tell this is a neonate because look at the size of the transducer compared to the liver and the kidney. The transducer is almost as big as the baby itself. You know, it's a so this is a really brand new spanking baby. I'm not saying spank baby, it's spanking new baby. But in any case, there's a hemorrhage there, probably due to some kind of traumatic birth. Pheochromocytoma, remember they have different appearances. They don't all look like this. Intermittent headache and hypertension. Presentation on this particular patient was intermittent headache and hypertension. Neuroblastoma, we'll talk about that with pediatrics, but I just wanted to show you they can be quite big. And adrenal adenoma, so we have a solid, nice round solid tumor here, superior to the kidney. This one appears right in line with the kidney. Left kidney, because that really looks like a spleen over here, so that's got to be left kidney. That's pretty cool, and that is that. So, escape. Look at that. What all we covered today. That's awesome. All right, let's